My name is John Allan. I'm a psychiatrist. I'm the Executive Director of Mental Health, Alcohol and Other Drugs in Queensland. I'm also the President-elect of the College of Psychiatrists.
That I did not know. Very good to have you here. Now, you've just been involved in a panel discussion that really is about trying to get government to act, and how do we go about things, and what do we put, how do we put it to them? What's your takeaway from that discussion and more generally from today?
Look, I think it's been a really great day. People have talked about a lot of practical solutions, and we've seen some really great examples of that from people. For example, being able to work with police to reduce the impact of a mental health crisis, having peer workers to help people support, making some changes around diversion from ED departments, and thinking about what that ED thing is in the journey of a person who has a serious mental illness. But I guess there's some other things that happened today as well. One was that I was really impressed by the fact that we started out with two great presentations, one from a person with lived experience who really described all the things that went wrong over a long period of time in an emergency situation, but how she's been able to recover and get back her human dignity from that. The second one was a really powerful presentation from Western Australia where they actually filmed a period of time of a person presenting to an emergency department where they showed what happens when a person, as they say, arcs up, gets sedated, gets shackled to a bed, how they react, how people react to them. And I was reflecting on that, thinking, this is what it's all become. How do we get to this position where that kind of behaviour from people who are caring and who want to do a great job actually accept that as a normal way of behaving? And I wondered whether we'd talked about that in the room today. As I said, we talked about a lot of solutions and about money and beds and community services and so on, but we didn't talk about some of those things that I think are a bit unwritten and unsaid. And to me, to get like that, there has to be some kind of organising principle, something that really strongly drives us towards that, because we wouldn't choose to do that. We wouldn't choose to behave so badly. And I just wondered if we'd talk about that, and the things that I note are reductionism, like just bringing it all down to one simple idea about mental health, good or bad, and particularly stigma, where somewhere unconsciously we don't really feel that people who've got a serious mental illness or other mental health problems deserve to get the level of care and treatment that other people get. I heard us talk about general ED patients versus mental health ED patients, and I think, I wish we're over that. We should have been over that a long time ago. So that to me is quite worrying. However, on the positive side, we talked about the notion of being able to set some targets that we could all agree upon, which explained and looked at how we can improve people's experience, not just of the care they get, but the outcomes they have. So if we went in with a particular problem, how can we measure that problem got some solution? We're already starting to do that on a national level about suicide prevention. So we're talking about people who show up with suicidal or self-harming ideation or events, what sort of follow-up they're getting, how can we change that, what's the relapse rate going to be, how do we make a difference in their lives. And so we need to come to some really strongly nationally agreed target. The other thing is about getting change. The mental health sector has had lots and lots of great ideas, but they all we never pull together properly. We all have opposing views about what works, like should we have more beds, should we have more community? There's evidence that's quite strongly there, but we have to agree. Government always saying, what do you want? It's a big problem area, but no one can actually come up with a plan. And when we do come up with a national plan, it gets ridiculed. When we come up with local initiatives, people say, oh, but what about this? It wouldn't happen, I think, sometimes in things like cancer. We wouldn't actually have that kind of divisive effort. So I just wonder what it is that we're doing wrong. What's the unconscious thing that stops us from getting that right? I've devoted 37 years of my professional life to this. I've thought about it for a long time.
So, and therefore, what are your answers to some of those questions? And one for what we can get out of today's efforts to actually go forward and try and get some change happening. But also, what do you do about those intractable big questions that you're asking about how we actually feel, stigma, etc.?
Well, I think the main thing is that it's about societal change. I mean, there's inherent good in everybody, and I think all the people in this room actually bring that inherent good. But trying to change society is really quite hard. I mean, it's one of the things that we've done really badly is we've medicalised the social determinants of health. We've turned distress into a medical thing or an industry, whereas in fact sometimes we have to learn how to deal with suffering, we have to learn how to deal with difference, we have to learn to accept people for their differences and so on. That's what recovery is about, and that's what destigmatisation is about. So we have to do that. But secondly, I think we actually demand a higher service standard than we used to. Yeah, I don't think it's right that people with mental illness should die 25 years younger, whether that's smoking or exercise or drugs or something about the illness. I don't think that's right. That's not what we should accept. So the solutions are that the level of care that we give to people with mental illness have to be exactly or better than the level of care we give to everybody else, because they're actually people who are facing more and more difficult problems. They might have double whammies, they might be homeless, they might have other things. So we have to actually be really careful about the way that we structure and do things. We have to base it on evidence, and we have to apply what we already know. For example, we know that if we put up a really good system around suicide, we could reduce 30% of the suicides. We probably can't reach more than that just yet on current knowledge, but we could actually do that. And yet the suicide rate is going up because we show a reluctance to be coordinated and do that all together. So my plea, I guess, is that we use the enthusiasm we have in the room to actually go out in our real lives and do that properly together.
And are you hopeful of that?
Sorry?
Are you hopeful of that?
I'm ever hopeful.
Thank you.
I've been hopeful for many years.
And thank you very much.